Hi everyone, my name is Baweja. I'm one of the assigned members here at New York Medical College, and today I have the pleasure of talking to Dr. Nogles. She's a neurohospitalist and vascular neurologist. Dr. Nogles, thank you so much for joining us today.
Thank you for having me.
So to start things off, can you start by telling us why you chose to become a physician and a neurologist?
Yeah, absolutely. So I had decided on pursuing a career in medicine pretty early. I knew I wanted to be a doctor during high school. Um, Initially, my main interest was in psychology and psychiatry. So my initial plan was to become a psychiatrist. When I went to college, I studied neuroscience, and became more interested in neuroscience and neurology. Um, and during medical school, during my rotations, was actually when I made my decision about neurology. I really liked the fact that it feels kind of like detective work. So a lot of times it's like kind of putting together the pieces of a puzzle to solve this mystery of what's going on with somebody. Um, and, with the imaging modalities and everything, I just found it to be very interesting and very satisfying. And I ended up going into neurology. Additionally, though, some of the neurologists that I worked with, were part of the reason I pursued a career in neurology as well.
Okay. And what led you to pursuing a fellowship in vascular neurology?
So stroke is actually what kind of caught my attention initially in going into neurology. Um, when I was a medical student, a third year medical student, there was a patient who had aphasia. And based on examining her and trying to talk to her, um, I predicted, where the stroke was going to be. And when I brought up the MRI, I thought it was so cool that I knew exactly where it was just based on the exam. So that was what initially got me interested in neurology. That was the first case that really grabbed my attention. Um, when I started my residency, I actually was considering doing movement, but I found that I actually really liked the pace of doing stroke alerts and the inpatient setting. And I felt like, most of movement is outpatient, and I just didn't feel like that was the right fit for me. Um, I really liked the speed of vascular neurology and doing stroke alerts and how quickly everything needs to be done. Um, so that was kind of what got me into doing stroke.
Okay. And could you describe like what a typical week or month in your life would look like?
Yeah, absolutely. So I'm a neurohospitalist. So what I do is 7 on, 7 off. So similar to what you'll see with just like a medicine hospitalist, the same kind of schedule. So I work 7 days and then I have 7 days off. So my day is usually I'm a consult only service. So I go in, I see, the new consults and the follow-ups. I don't have anyone admitted primarily to me. So I see everyone as a consultant. I do stroke alerts when I'm in-house. But fortunately, we have telestroke. So when I'm not in-house, I'm not in, I'm not responsible for the stroke alerts. I just get called with any kind of questions about patients I've already seen, those kind of things, more routine questions. So I do take home call. So when I'm on for 7 days, I'm on for the whole 7 days. But just fortunately, with the way my hospital works, I don't get that many calls overnight usually. And then during my 7 off, I'm off. So I can kind of do whatever I want and whatever I need to do with that time to take care of things, other than work.
So for as part of your hospice, is it only stroke patients you see or do you see other neurological patients?
That's a great question. So I am a general neurohospitalist. So I see, a large chunk of the patients I see are stroke patients, but I see any patients who come in with a neurological issue, I see those patients. So it's not all stroke. There are stroke hospitalists physicians out there, but that's not the type that I'm in. So I see all types of neurological cases that require hospitalization or things that pop up during hospitalization as well.
So what are some of the most common ones you'd say you'd see?
So, I mean, stroke is definitely up there because that's a big neurological issue that puts people in the hospital. Um, I also see a lot of seizures and status epilepticus patients. Um, and then, of course, encephalopathy, altered mental status. You have patients who are in the hospital for long periods of time. Of course, things are going to come up. Um, so I see a lot of that as well. Um, and then, people who come in the hospital with intractable headaches and migraines, I'll see a decent amount of that as well. Um, and then neuropathy is pretty common too, because it, makes people fall a lot, which is something that I didn't necessarily expect when I, became a neurohospitalist, but patients will fall a lot. They get a neurology consult and you find that they have neuropathy. So that's something I see a pretty solid amount too. Um, and then I see a myasthenic patient occasionally. But those are kind of the main things.
Okay. And what would you so neurology has changed a lot from what we've learned. What would you say is the biggest changes that you've seen and predict will happen in the next 10, 15 years?
So even since I did my residency, TNK was approved to Nectaplace. So when I did residency, we used TPA, the Altaplace, in acute stroke. Um, and now most places are using TNK to Nectaplace because it's not, if you know about TPA, it's an infusion. It runs for an hour, but with tenecteplase, it's just a one-time push, so you don't have to leave a drip going. And it was recently approved by the FDA, so I feel like that's definitely one of the biggest things. And I feel like stroke is something that's always changing, the interventions that are available and everything. But I think that another thing that seems to be really evolving is the management of dementia, which is obviously more of an outpatient thing that I don't see as much, but I see plenty of delirious dementia patients when they're in the hospital. Um, but there's research being done now on monoclonal antibodies and management of dementia. So I think that we're going to see a lot of changes in the field of cognitive neurology in the near future.
Okay. And for any medical student who's interested in pursuing neurology, what advice would you have for them?
I think that, if you're interested in neurology, the biggest thing is to really try to kind of see as much as you can. Um, in terms of rotations, I don't know how it is now, but when I was there, I did a stroke rotation during my fourth year. I don't know how much it's changed, but I think getting exposure to as much as possible can be very helpful. And I didn't do any away rotations when I was a medical student, but I think seeing how other places do things could also be very helpful. So if you can get away rotations. Um, and I think another thing to just really think about in terms of if you're debating neurology as a career is the practice of neurology and being a neurologist is very different than what you do in terms of what you learned about neuroscience and neurology in the classroom. Um, it's it's a lot of, I remember as a medical student learning about the corticospinal and spinothalamic, and it can all get very overwhelming. And I think the actual practice of it, the more patients you see, obviously, the more useful it is and the more you'll learn. But, the practice of it is very different than what you learn in the textbook.
Okay. And for a last question that we like to ask everyone, what's your favorite part of the brain or central nervous system and why?
Um, I think I think my favorite part of the brain is the thalamus. Um, it's very complicated. It has so many different functions because it's really where everything kind of comes together. And I know that, when you're first learning about it, a lot of times thalamic strokes, we think, sensory deficits, but there's just so much that goes on with the thalamus that it can cause so many different kinds of presentations and symptoms. So I love the complexity of it. It really keeps you on your toes. So I think I would say it's thalamus.
Well, thank you so much for joining us today, Dr.
Welcome.
Nogles. Um, yeah, it was really insightful to hear from you.
Well, thank you so much for having me. Good luck with everything.
Thank you.